Good morning. Good morning to all of you. Thank you. I'm Victor Dzau, and I'm so pleased to welcome you to this public report release event. And the report is called Taking Action Against Burnout, a System Approach to Clinician Well-Being. So our nation is facing an epidemic of clinician burnout. Last several years, the medical community has recognized an alarming crisis of physician burnout and suicide, although the public remains largely unaware of it. So it is in the interest of assuring quality of patient care and well-being of our clinicians that today's report is released to shine a spotlight on the crisis and recommend solutions to prevent it. Now, the epidemic of burnout affects both those in training as well as those in practice. Over 50% of physicians and 45 to 60% of medical students and residents have symptoms of burnout. Furthermore, physician rates of depression or suicidal ideation remains very high as 40%. This issue is not unique to physicians. There are high prevalence rates of symptoms of post-traumatic stress disorder, emotional exhaustion among nurses, and many other health professionals. The trend is alarming itself, but even more so when we consider the impact of patients and society. Burnout has been linked to self-reported errors, patient dissatisfaction, a reduced ability to express empathy. Burnout may result in increased familial problems, stress-related illnesses, automobile accidents, and substance abuse. Clinician burnout is a threat to patient quality care. So these facts are really disturbing, and we must act urgently to reverse these trends. Not on my script, and I'll tell you two stories. When I was a resident back in Boston, I had an all-night. I actually was a senior resident. I sent one of the junior residents home so that he can get some sleep because he's on 2 nights in a row. When I drove home, my car went off the road. And before I can even wake up to it, I saw myself hitting a fence and ran to someone's backyard. Thank God no one was hurt. And that's when you have tiredness and burnout. And I really thought of leaving the residency, and I think Derek heard me talk about that before. The second issue is that I always say, if physicians are burned out or clinicians, can you imagine that you go to an airplane and the pilot says, I'm burned out? So that, I think, emphasizes how important it is to address this issue, because it is also not only about the clinician's well-being, but also the patient's well-being. Now, it has been said that personality traits of clinicians, that is high-achieving, hard-working, caring, predispose them to burnout. These qualities, coupled with concern for stigma, appearance of weakness, and fear of vulnerability, the so-called culture of silence, have kept clinicians from acknowledging the problem and seeking help. As the committee will discuss, burnout is not due to weakness of the individual or problem of mental health. The heart of the problem lies with demands in the work environment and added pressures of external factors such as policies and regulations. The rapid changes in the practice of healthcare over the past several years, including mergers, consolidations, increased patient demand, introduction of electronic health record, extensive documentations, changes in reimbursement, changes in regulation by government insurance, have resulted in a very large demanded workload, high productivity expectation, and more time spent on administrative tasks. As a result, clinicians have less time to interact with their patients and also with each other, their colleagues, let alone to attend to their personal lives. As the healthcare community recognizes this problem, many hospitals, medical centers, training programs have sprung to action. Many have different interventions, programs of wellness, and others have developed. But many of these actions are done in isolation and not through coordination. So until recently, there's been no collective effort to study and document the outcomes of the various activities. So there's a real need to solve this problem together systematically to research what works and what doesn't scale, and scale the successful one to a national level. This is how we got involved. The National Academy of Medicine, as an effective convener, has brought to the table organizations that are developing solutions with many stakeholders, policymakers, insurers, educators, health system leaders, and health information technology experts. When we launched the Action Collaborative on Clinician Wellbeing and Resilience, and that involved a network of more than 200 organizations working on this. Although the collaborative had been quite successful, it became very clear in the collaborative there's more work to be done, and that a consensus study would further elevate this issue to national and international importance and lead to meaningful change, which is why we're here today. We're so pleased that we're able to convene and commission a consensus study to evaluate the available evidence on clinician burnout and well-being and make recommendations for change. You hear this outstanding committee, and I thank them, and we'll have a chance to thank them personally, have done a work of over 18 months and look at evidence, review and deliberated on the evidence, and develop recommendations on designing systems to reduce burnout and foster professional well-being. I think you see that this resulting report is a bold vision for redesigning clinical systems, one that focuses on activities that patients find important to their care and enables and empowers clinicians to provide high-quality care. So once again, I want to thank this fantastic committee and, of course, our staff for the outstanding work. They put long hours to tackling this topic, and I think that I'm sure that we'll see the efforts not only reflecting the report, but impacting our society altogether. One last word. You know, we believe that consensus study and reports have such influence because, as you know, in the National Academies, consensus report influenced the trajectory, in this case of health, and by instigating policy changes in organizations, government, etc. Nearly 20 years ago, the Institute of Medicine, the precursor organization of the NAM, launched the modern patient safety movement with publication of 2 landmark reports, To Err is Human and Crossing Quality Chasm. And these 2 reports, too, call out the real important issue of a crisis and actually provided solutions that have really transformed patient care. We are confident that this report will have a similar report for the field, calling attention to safety, health, and well-being of our clinicians, and of course the quality of our patient care. So I'm going to end by saying that we recognize the recommendation report must be translated to action. As you hear shortly, we built a robust communication plan, and for the report, an action collaborative will also advance many of the recommendations. So once again, thank you. I do want to particularly call out and thank the co-chairs, Pascal Caruana, who's here, thank you, and of course Chris Castle, who actually will join us, I believe, electronically. So they will take it from there. Thank you very much for being here.